Hello students, welcome to Distinction Name platform, and on this platform you find revisions, expression to difficult topics, you find test quizzes, a lot of stuff. So before we begin our video, make sure that you subscribe so that you can be updated with all upcoming videos. To make the story short, let us begin. And don't forget to like the video, okay? So in this video, we're talking about placental abruption. I remember that this is under what? Clinical session, which is obs and gyne. Okay, so placental abruption, this is an obstetric emergency. Basically, what it means is that if someone comes to abruption placenta, basically you need to intervene without hesitation, because this is a very dangerous obstetric emergency that can endanger both the mother and the fetus. Okay. And this one, if you talk about the occurrence of the abruption placenta, it occurs like the occurrence worldwide is it has been estimated about 1% or 0.4%. Okay, basically that is according to if you talk about the number of pregnancies, it occurs about 4 to 10 birth per 1,000 birth. It's going to occur in that way. But according to Zambia, it also has been estimated that it also occurs about 0.4% in all pregnancies. Basically, that is also about 4 deliveries. They are going to experience placenta rupture in about 1,000 birth. That is according to Zambia. Okay. So now, what is placenta abruption or abruption placenta? What is it? So abruption placenta basically talks about the separation between the placenta itself and the uterine wall. So what are we saying? What is abruption placenta? So basically abruption placenta is separation of the placenta and the separation of the placenta and the uterine. Oh, if there's that separation, then that is abruption placenta. So that is the premature separation. It has to be premature. Okay. Basically, since this is one of the cause of antepartum hemorrhage, which is abruption placenta, basically it's mostly occur after the age of viability, which is greater than 28 weeks. Remember that age viability can differ. Others they consider it to be low as 24. Others much lower as 20 weeks gestation. Okay, so that is a placental abruption. If you look at this diagram, okay, if you look at this part, this green part is this is the placenta, okay, and this is the uterus or uterine wall. Okay, so now abruption placenta happens like if there's this separation, there is separation between the uterine wall and the placenta itself. Okay. Now, this separation, if there is that separation, remember that between the placenta and the uterine, there are some arteries there, okay? Those arteries, if there is a separation, they are going to rupture. Basically, they will be bleeding. And that type of bleeding is what we call retroplacental bleeding. So retroplacental bleeding is just the type of bleeding that's going to occur between the uterus and the placenta. Okay, so here there will be bleeding. Okay, here there will be bleeding. Now this bleeding can dissect between the placenta and the and the uterine. So this bleeding can come out like that, come out through the vagina like that. Okay, and it's going to cause what we call the vaginal bleeding. Okay, the vaginal bleeding. It's going to present like that. But I'm not saying that all the abruption placenta they are going to present with vaginal bleeding. But commonly they are going to present with vaginal bleeding, because there is also another type of the placenta abruption, which is concealed abruption placenta. Concealed abruption placenta, which we'll talk about under the classification here, we'll understand more. But that one doesn't it's not going to a pregnant woman is not going to show the symptoms of bleeding. Okay, but they're having abruption placenta, so we'll talk about that. And that category is a dangerous one, and it's very hard to diagnose. Very, very important. Okay, now let's talk about something else. So what did we say about the incident? The incident, we said, incident of this placental abruption, what did we say? We said it's about what? 0.4% of all pregnancies. Okay, this is what we said. All pregnancies. Okay, basically same applies to Zambia as well. It has also been estimated to that, and also most of the what countries, and also worldwide. Okay, according to the research. Now, since we've understood the abruptio placenta or the placental abruption, then let's talk about what can really predispose someone to have this dangerous what or this obstetric emergence. Then let's talk about the what risky factors. Okay, what are those now? So the first one is very, very simple, because you're going to be asked about the risk factors for abruptio placenta, because you need to know the risk factors of abruptio placenta so that you don't have it in future, okay, or so that you can prevent it. So what is the first one? So the first one, someone who had history of what? The same one, which is what? Abruptio what? Placenta. History of what? Abruptio placenta. This is the first what? The first risk factor. Someone who had in the previous pregnancy, they had abruptio placenta. They are at increased risk of developing what? Abruptio placenta. Also maybe in the current what? Pregnancy, or in the future pregnancy. Okay, that's the first one. What is the second one? Okay, also hypertension. Okay, hypertension. Okay, hypertension predispose someone to have what? Abruptio placenta. Basically, if you remember, we talked about hypertensive disorders in what? Pregnancy. Basically, we said there are 4 categories of hypertensive disorders in pregnancy. There is gestational hypertension, there is what? Preeclampsia, there is what? Chronic hypertension, and also superimposed preeclampsia on what? Chronic hypertension. We talked about that. So those conditions, they can predispose someone to have what? Abruptio placenta, or the separation of the placenta and the what? Uterus, or which is the premature separation. Okay. Okay, now that is the risk factor. Okay, what else? Apart from that, there is also another one. It has also shown that smoking, okay, someone who smokes, and also cocaine use, and what? Cocaine use. Okay, cocaine use, they are at increased risk of developing what? Abruptio placenta. Why? Because these smoking and cocaine, these are what? Vasoconstrictors. If they are vasoconstrictors, they are predisposing someone to have what? Hypertension. And hypertension, what did we say? Hypertension is one of the risk factors of what? Placental abruption. Basically, and definitely, smoking and cocaine use is one of the what? Risky factors. What else? So apart from that, there's also another one. There is what we call also increased maternal age. Okay, increased maternal age, okay, increased maternal age is one of the risk factors as well. Okay, okay, what else? Also, let's talk about this interesting one. Prom is what? So increased maternal age, basically that is very simple to understand. Okay, now what about prom? Prom basically means this P stands for premature, R stands for rupture, O stands for of membrane. So premature rupture of what? Membranes. So basically premature rupture of membranes, that's the rupture of fetal membranes before the onset of what? Labor. So basically, this prom, if those membranes are ruptured before the onset of labor, then it can to predispose someone to what? Have the separation, premature separation of the placenta and the uterine, between the placenta and the what? Uterine, causing what? Abruptio placenta. Very, very important. So we'll talk about prom in more details about that, because there are 2 types of prom, term prom and what? PP prom. Okay? So, okay, let's talk about another one. Okay, so what else can predispose someone to have abruptio placenta? Also, what we call maternal trauma. trauma is a very important one. Okay, trauma. So basically, under maternal trauma, from history, you need also to ask the patient if they had history of trauma, because history of trauma is one of the risk factor or cause of what placental abruption. Okay, very important. Okay, so and basically these are the important risk factors that you need to understand. Again, maybe if you talk about the polyhydramnios can also predispose someone to have what? Abruption placenta. There are a lot of what? Causes. Okay? Now, apart from the risk factors, now what else are we supposed to talk about? Now, let's talk about something also very interesting. Let's talk about on how you can classify that same premature separation of the what? Placenta from the what? Uterine, or which is abruption placenta. What is that? So classification is based on what? Severity or clinical, which is the common one that they use. Okay, and also there is an anatomical classification, but also there is another one which we say classification based on the extent of the separation. So we'll talk about that as well. Okay. Okay. Now let's talk about the first one. Based on severity and clinical classification. So based on severity and clinical classification, if you say severity, basically you already know that severity, it will be mild, moderate, and what? Severe. So there are three. Okay. So based on this, there will be what? Mild, which we'll talk about. Okay. There will be what? Moderate. Okay, which we'll also talk about. And what? Severe, which we also talk about. Okay. Now, mild, sometimes if you are using grade, this is what? Grade 1. Okay. This is what? Grade 1. And this is what? G2. And this is what? Grade what? 3. Okay. So those are the clinical classification. Now, clinical classification, what are the main important things that you consider or that you should consider under clinical classification? Basically, there are 4 important things that you need to what? Consider. You need to talk about the what? The bleeding itself. The first one is what? Bleeding. You need to talk about the what? The bleeding. We are going to characterize the bleeding. Okay. What else? There is also another one, fetal monitoring. So we'll talk about the fetal monitoring as well. Okay. What else? So I said 4 important things. This is 1, this is number 2, then number 3. What else? Also, you need to talk about the pain, because someone coming with abruption placenta, they are going to have pain, which is the rapid in onset. Okay. We'll talk about that as well. Then number 4. Okay. What is number 4 apart from that? There is also what? Placenta separation, placental separation. Okay. Okay. Let's start with the bleeding. Okay. The bleeding is what? So number 1, under mild or grade 1 placental abruption. This is what? The bleeding is what? Mild. Okay. It is mild. The bleeding is mild, but the bleeding itself, remember that what the characteristics of bleeding we'll talk about under history. So remember that we need to ask the patient when the bleeding started, okay, and for how long, what's the color. So remember that the normal color for someone presenting with what? Abruption placenta is what? Dark red for the what? Bleeding. Very important. And also ask about if the bleeding is associated with the pain that we'll talk about here. Very important point that you need to what? Talk about. So what's the color of the bleeding? Basically, we know that that is what? Dark red. But why am I stressing enough on the what? Clinical classification of what? The placenta abruption? Because they use these same things to diagnose what? Placenta abruption. Why? Because if you talk about some imaging like the ultrasound, quite alright, it's going to be used to diagnose abruption placenta, but the sensitivity of that imaging is not what? Is not great, or is not high, it is low. Okay. Sometimes they are just they just concentrate on the what? Clinical features of the placental abruption. Okay. Now let's talk about the fetal monitoring. So fetal monitoring, they use what we call CTG. Okay. On monitoring, they use what we call CTG. Okay. CTG. So what is CTG? Okay, CTG basically that is it stands for, this is cardio tonography. So that is cardiotonography. It's used to monitor the fetal heart rate. Now, if you look at the mild or the grade 1, here there will be what? Normal. Okay? The normal, there will be what? Normal heart rate of the fetus. So there will be no deceleration, there will be nothing like that. So the fetus C is what? Normal. So normal what? Heart rate, fetal heart rate, fetal heart rate. Normal fetal heart rate. Okay? There will be nothing that's going to be what? Strained on the what? On the CTG. Okay? Now let's go to pen. The pen here is going to be what? It's going to be mild, okay, and what? Also localized. Okay. The pain there is not going to be so severe, it's going to be mild and localized. Okay. What about the placental separation? So when it has been estimated that we need to be using what? Percentage. So what is the percentage of separation under mild? So the percentage separation under mild is going to be what? Less than what? 20%, 20% separation. Okay. Then it's going to be considered under what? Mild placental abruption. Now, so if you talk about these clinical classification, they're going to help us to manage also the patient according to the what? Grades as well. Grade 1 is going to be managed different from grade 2 and also from what? Grade 3. So also you need to know the grades of that. Okay. So also here we're going to do the same thing. So number 1, we'll talk about the bleeding. So let's now be fast. So the bleeding here, if it was mild here, it will be here moderate. Okay. Number 2, if here the fetal monitoring, so here I'm going to specify something. Monitoring. So fetal monitoring, what can you see now on CTG? Okay, on CTG now you are going to see something which is very, very important. There will be what? There will be tachycardia. Okay. There will be what? Tachycardia. Okay. There will be tachycardia. What else? So there will be now moderate or mild what? There will be mild or moderate. So let's just say mild deceleration, late deceleration. Okay. Mild deceleration. So I need to talk about what it means when you say deceleration. So if you are monitoring the fetal heart rate, okay, if you see some like drops in the from the normal heart rate of the fetal, then you see drops, the heart rate is dropping like that, then that's what we call deceleration. Okay, now there are different types of deceleration. There are what we call early deceleration, there are what we call late deceleration, prolonged deceleration, and what? Variable deceleration. If we talk about the early deceleration, these are what? Normal deceleration. Why are they normal deceleration? Why the fetal heart rate is dropping like that, but it's normal? It's considered benign under early deceleration, because if the uterus is contracting like that, in the contracting normally like that, then that contraction is going to compress against the head of the fetus. Then the fetus is going to feel what? The fetal heart rate is going to be decreased due to the compression of that, but that is considered to be normal, not abnormal. Then late deceleration. Now these are abnormal what? Abnormal deceleration. Basically, it's because of what? A certain condition. Maybe there is cold prolapse, there is what? Abruption placenta. But here there will be what? Mild late deceleration here. So basically, that deceleration is not that severe. So late deceleration are abnormal deceleration due to what? Hypoxia to the fetus. Okay. Now that's about that. So there will be mild deceleration. So since we've understood about that, now let's continue. Number 3, let's talk about the pain. Basically, the pain that is the uterine pain. Okay, uterine pain. There it was moderate. Here it was mild. Here it will be what? Moderate what? Moderate uterine what? tenderness or tenderness. Let me just say tenderness. Okay, like that. So moderate with and what? Tenderness. So the pain is just now moderate. So it will be now under grade 2. Okay. Then the last one is what? Placental what? Separation. Placental separation. So placental separation to be now between what? 20 to 50%. They need to be considered under what? Moderate or grade 2 type. Okay. Now let's talk about the other one, the G3. The G3 now, G3 is going to have also the same things. Bleeding, okay. The bleeding here will be what? Severe, okay. Then number 2, fetal monitoring, okay. Fetal monitoring. Now you're going to see under CTG, you're going to see instead of tachycardia, you're going to see bradycardia. Okay, very important one. So you're going to see bradycardia. Okay, what else? There will be now, instead of mild or moderate, there will be moderate, severe, or severe what? Late. Let me just say this. So late deceleration, bradycardia, moderate or severe, late deceleration. On here, under fetal monitor, you can even see fetal what? Death or fetal demise, because now this is now, it has become what? Severe. So the fetus can now die due to what? severe hypoxia. Number 3, if you talk about the pain, there will be what? Here there will be now severe what? Pain. Okay. This pain now, I'm going to be more specific. They call it knife-like what? Pain. Okay. The character of this severe pain is knife-like what? Like pain. So basically they say the stabbing pain. So if someone now, they say, the pain is more like stabbing me like that. So it will be now an indicative or an indication that, okay, this one is under what? Grade 3 type of what? Classification. Okay, what else? Placental separation. So placenta separation now, it will be now greater than what? 50% here. Okay, it will be greater than what? 50%. So that's under the clinical classification. Very, very important. Make sure that you go through these. These are very, very important ones. So for you to diagnose that this is under grade 1, at least they need to have what? These all features. Not just one at, okay, there's a mild bleeding, then this is under what? Mild placental abruption. No, they need to have at least these 4 features, then you are going to consider them under mild, moderate, or severe. Very, very, very important point to consider. So now let's talk about the other classification that we need to understand. Okay, what is the other classification? We said this is anatomic what? Anatomic classification. Okay. So anatomic classification. So what is that? Anatomic classification is based on the anatomy of the placental abruption, or where the placental abruption is what? Happening. Okay. Basically here there are just 3 types of what? Anatomic classification. What is the first one? The first one, let's start with a simpler one. Let's start with what we call reviewed. Okay. Reviewed abruptio placenta. Let's just say PA. So reviewed placenta abruption, and this one is the most common one. Okay, and it's about what? It carries about 8% of cases. This is the most common one, and here the most common one is what? Mild, but these, they are rare. If they happen, basically the patient, they are to increase the risk. Okay. So now this, so let us understand about the reviewed. The other term that they use under reviewed, they say the external type of what? the external type of the placenta abruption. So this is the external type. So the other term that they use is external placental what? Abruption. So placental abruption. Okay. So now, what can you do? So what do we understand about reviewed? So reviewed or external, here we are able to see what? Blood. So we are able to see the bleeding here. So what can you see here? Bleeding is what? Bleeding is visible. Okay? Bleeding is what? Visible. Why? Because if you talk about here, okay? The margins, so if you look at this part and this part, these are the margins of the what? The margin of the placenta and the uterus. Here, if the margin are going to be disrupted here, blood is able to dissect between the placenta and the what? Uterine. Or if it is able to do that, basically it can come out like that. That is under reviewed. All the membrane, they are going to what? Dissect. Blood will start passing through the membranes and it will come out like that. And they are going to present with what? Vaginal bleeding. Okay? Vaginal bleeding. That's according to what? Reviewed. Okay? Okay? And let's talk about another one. Another one is what we call concealed. PA. Okay? This ranges about what now? 20%? 10%. So concealed basically the bleeding, you are not going to see vaginal bleeding because it's concealed. It's not the bleeding is not coming out. The question is, why is the bleeding not coming out? Okay, the reason why the bleeding is not coming out, because the margins here are intact. Okay, the margin of the placenta and the uterine are intact, they are not dissected, and basically the bleeding is going to, the dissection basically is happening on the center somewhere here. Okay, on the center somewhere here, on the center here. So if the bleeding is happening on the center there, it's going to it's not going to actually start coming over here to start dissecting the margin. So basically the bleeding will be just there, okay? Unlike this one, the viewed dissection happens near to the what? To the margin, so that now the margin can also be dissected so that blood can start what? Coming out. No wonder sometimes concealed is also called central. Sometimes it is also called central or the internal. PA. Okay? This is the reason why it is also called that. Now, there's an important point that you need to take a note on the concealed. Remember that under concealed, there is no vaginal bleeding. So we're going to say no vaginal bleeding. You're not going to see here. No vaginal bleeding. And concealed one is what? It's a dangerous what? Type of the what? Type of the placental abruption, because this one can kill the patient. It has higher mortality rate. Very important to take note. And there's something that can happen if the bleeding is not going anywhere. Here, it is just there on top, there between here. This is the retroplacental what? Hematoma. But this hematoma, what can happen is this. This hematoma now, that blood that has been coagulated there, it will start what? It will start going to the what? Uterus muscles there. So the blood now will start going to the uterus muscles. And what do we call that? When the blood is going to the uterus muscle, there is a term that they use. Okay? They use what we call it covelea. I don't know the way you are going to pronounce this. Covelea uterus. Okay? So covelea uterus basically is talking about in the uterine muscles there, what there's the extravasation, there's blood in the uterus muscles there. Okay, that is covelea uterus, and it's a very diagnostic thing that you can use under concealed what? PA. Okay, so that's the important one. Now, what is the last one? According to anatomic classification, the last one is what? Mixed type. Okay, mixed type. Basically, it's going to have what? It will have both features of what? Both features. But this one is rare, having both features. So you are going to have both features of what? Reviewed PA and they see concealed PA. Okay, so you are going to have that. If you see there's cover layer, you see maybe there's also like a mouth blood bleeding that's going to be seen, then you are going to see, okay, that is a mixed water type. It can also happen. Okay, now remember that, okay, apart from this anatomic classification, I said there is also another classification that you are going to encounter as well. There's what we call classification according to the what extent of the placenta separation, or where the placenta separation is happening. So we'll start with what? The marginal abrupture placenta. Marginal abrupture placenta. So marginal abrupture placenta, as you can see, these are margins that I talked about. If there's a separation on the margin here and the blood is able to come out like that, then it will be what? Marginal abrupture placenta. And marginal abrupture placenta basically they correlate with what? Reviewed the abrupture placenta. Okay, the marginal one. Okay, apart from the marginal one, there is what we call, so there's marginal, okay, there is also another one, partial abrupture placenta. So partial abrupture placenta, now it is considered under what? Mixed type. So partial abrupture placenta, the placenta and the uterine, they are going to be partially separated, dissected. Okay, if they are partially separated, now what's going to happen? There will be what? There will be the features of concealed, and there will be what? The features of what? Revealed. No wonder partial abrupture placenta is going to be under what? Mixed type. The last one is what? The last one is what? Complete. Complete abrupture placenta, now it is under concealed abrupture placenta. Okay, where now there will be complete separation of what? The placenta and the uterine, but the margins are going to remain what? Contact, so that there will be no bleeding that's going to be visible. That's under another classification. You need to take note of that. Okay, now let's talk about the last part here. Let's talk about the last part, the clinical features and what? Diagnosis. That should be the last part. So what are the clinical features when someone comes with what? Placental abrupture. So what is that? The clinical features basically, or the diagnosis that you need, first of all, you need to talk about history. Remember, examination or exam, and also the investigation. So what are we supposed to know about that? So clinical features will come from what? History. Okay, we'll talk about also exam. Okay, then what else? Also investigation. Very important. Okay, from history, okay, basically some people come with what? Vaginal bleeding with some complete pain like that. Okay, so what are we supposed to talk about? Remember, if someone comes with the vaginal bleeding, ask them about what? The characteristics of what? The bleeding that they're having. Okay, remember that the bleeding that they're going to describe, if it is a abrupture placenta that you're suspecting, they need to describe it as what? Dark what? Red. Okay, that's the color. And remember that the quantity of the bleeding doesn't correlate with what? Severity of abrupture placenta. Why? Because there is another anatomic classification of what? Abrupture placenta, which is the concealed PA. Concealed PA is a severe what type of PA, but there is no bleeding. So basically, the quantity of bleeding doesn't necessarily talk about the severity of what? Abrupture placenta. Very important. So we talk about that. Also ask about when did it start? Is it associated with pain? Okay, and how long has the bleeding been there? How many sanitary pads do they use per day? So you need to quantify that as well. Okay, so also ask about what? Ask about the history of trauma. Okay, ask about the history of what? Trauma. Very important. Okay, history of what? Medical condition, maybe coagulopathies. Okay, coagulopathies. Okay, like the liver disease, those things, thrombocytopenic disorders, those disorders as well. Ask about that. Okay, so what else? Also ask about what? Fetal well-being. Okay, fetal well-being by simply asking the mother if she has been perceiving what fetal movement. Okay, make sure that you understand that. Okay, so you ask about that. So that is from history, although there are other things that you can ask from history. Okay, now let's talk about the exam. So exam, there are a lot of things that you can ask. Okay, there are a lot of things. Basically, first assess, since this is an obstetric emergency. Okay, basically after the patient is stable, then you can do an exam like that. Okay, after you stabilize the patient, you can do an exam. Or definitely maybe during the initial management you can do what? An exam. So talk about the management of PA. Okay. So now what do you do? First of all, you look at the general appearance of the what? Of the patient. You look at that general appearance of the patient, and what else? Also assess the vital what? The vital signs. You look at the blood pressure, look at the hemodynamic stability of the patient. Okay. Also, what else? You need to look for the signs of what? Anemia. Signs of what? Anemia. Okay, those are signs of anemia, cyanosis, those things, adenized blood weakness, like that. Okay. What else? Okay, also you need to examine the uterus. Remember that the uterus, since this is a abruption placenta, the uterus is going to be what? Tender. Okay, it's going to be tender, it's going to be hard. Okay, like it's described as hood hard, like that. So under uterus, under, if you are talking about what? The abruption placenta, it's going to be what? Tender and what? Hard. They describe as hood hard. Okay, like that. So that's under abruption placenta. But why do you think the uterus is going to be hard? It's because of what? The contraction. The uterus is going to be what? Contracting, like that. If the uterus is going to be contracting, it's the one that's going to cause what? Pain that you see, uterine pain. Okay? So it's going to be tender, hood hard, like that, because the uterus is contracting or over contracting. No wonder sometimes it is referred to as what? Hypertonic what? Uterus, because of those same contraction causing what? The pain. Okay, a lot can be done. Sometimes under an exam you can do also speculum exam, or maybe the the bimanual exam. Reason why you can do that, before you can do that, make sure that you, if you are not sure of the diagnosis, make sure that you exclude the placenta previa, because under placenta previa you can't do the what? Digital, the bimanual exam or the speculum exam, because you can exacerbate the what? The bleeding. So you need to take note of that. Okay. So that's under exam. Then what else? Investigation. So what are the investigations that you can do? So there are a lot of investigations that you can do. Okay, but I'll talk about the important points that you can what? Do. So under investigation, you can do lab investigation, where you look at the complete blood count or the full blood count. Okay, look at that so that you can assess the HB, the HB, the anemia there, the type of anemia that is there, so that maybe you can correct the complication. What else? So what else apart from that? You can do the clotting profiles. Okay, you can do the clotting profile. Okay, so that you look at the platelet count, look at the fibrogen levels, D-dimers, look at the partial thromboplastin time, look at also the prothrombin time as well, look at that as well, because someone is bleeding. Okay, that is clotting profile. So you can do a lot. Renal functional test, liver functional test, you can do that as well. Okay, now these are lab values that you can do. Now you can also do imaging. You can do imaging. Basically, you can do ultrasound. Okay, ultrasound. So now under ultrasound, if you find ultrasound to be negative, you can't see anything on the ultrasound. But doesn't necessarily to exclude what? Placenta abruption. Why? Because ultrasound is less sensitive when it comes to diagnosing what? Abruption placenta. It's less sensitive. Okay, so now the gold standard for diagnosis of abruption placenta is based on the what? Clinical features that you see on the clinical assessment, but not on the imaging using what? Ultrasound. Ultrasound is just used to what? Exclude the other code, which is what? placenta previa. So we're saying the reason why ultrasound can be used to diagnose maybe concealed this one PA. Also it can be used to diagnose revealed as well. Okay, sometimes they say it can only be used when the retroplacental clot is greater than 300 mils, like that. Okay, it can be used. Now here it is less sensitive. So the sensitive of ultrasound, it's about what? It's low. It's about 20% to what? To 50%. So it's very low, like that. No wonder negative result doesn't necessarily exclude what? Abruption placenta. Okay. Now the last part, now we're talking about what? The complications. So what are the complications of abruption placenta? Okay, and in the next video we'll talk about what? In the next video we'll talk about the management. But let's talk about the last part, which is what? Complications. So what are the complications? Remember that under OBS and GYN, if you are talking about complication, talk about what? The maternal complication and the fetal complication. Basically, you need to understand that. Okay. So what are the complications? What are the maternal complications? Maternal complication, we have, we know that there is hemorrhagic shock there. So there is hemorrhage there. Basically, they are going to have what? Hemorrhagic what? Shock. They are going to have some under maternal. There will be what? Hemorrhagic what? Shock. That's the first one. Okay. There will be what? So that's the first one, hemorrhagic shock. What's the second one? Renal what? Failure. Because if there is shock, there will be what? Multi-organ failure, renal failure, heart failure, a lot of organs they are going to fail. Okay. So what else apart from that? Apart from that, we are going to have also anemia. Okay. They are going to have what we call preterm labor. A lot of complication. What else? There will be also postpartum hemorrhage. Okay, there will be also postpartum hemorrhage. Again, maybe there will be Sheehan syndrome, like that. A lot of complication that can arise from maternal part. Then what about the fetal part? The fetal part, then they are going to have what? Remember, there will be what? There will be intrauterine growth restriction, IUGR. Okay, intrauterine growth what? Restriction. There is also intrauterine fetal demise, IFD. Okay, so intrauterine fetal demise, intrauterine growth restriction. There is also fetal hypoxia. Okay, fetal hypoxia. And there will be what? Increased risk of what? Congenital what? Anomalies. Okay, very, very important. So now that's where we end from, and make sure that don't forget to like the video and subscribe. Okay.